Okay, so diving in today, you're ready to explore pain.
Absolutely. Always ready to unpack this complex topic. It really touches everyone, you know?
It does, and I think a lot of people listening, they want to know more, about pain.
Yeah.
Not just like, oh, I stubbed my toe and it hurts, but like from a real health perspective.
Right, exactly.
What is it?
hmm
How is it assessed?
hmm
What can I do about it? So we're going to try to go through all of that today.
We are. We're going to take a real deep dive, kind of give you like the core knowledge you need to understand pain based on the latest health assessment guidelines.
Exactly.
So this will be good.
Yeah, this will be good. So let's just jump right in. Like, what is pain?
Okay, so pain, I mean, at a basic level, it's that feeling of discomfort.
Okay.
Right. And it can range. I mean, everybody has felt it. It can be anything from that very mild twinge
Yeah.
to something so severe that it takes over your entire world.
Yeah, like debilitating, can't even think about anything else.
Absolutely. And it's usually a sign that something else is going on, right?
Yeah.
Our bodies, they're really good at telling us when something's wrong. And pain is one of those big signals. It's saying, hey, pay attention. Something's not right here. And it can be short-lived, right? What we call acute pain.
Yeah.
Or it can be a real long-term companion, chronic pain.
Yeah, and I think something really important for everyone listening to understand is that pain is so subjective.
Oh, absolutely.
It's so individual. You always hear, pain is what you say it is.
Exactly.
And that is so true because the person who is feeling the pain is the ultimate authority on their experience.
They are.
Like, I can't tell you how much pain you're in. A scan can't necessarily tell you how much pain you're in.
That's right.
It's really up to the individual.
Mm-hmm.
I think that's really important to keep in mind as we kind of go through all this. We're going to talk about the different types of pain. Acute, chronic, breakthrough pain.
Mm-hmm.
Talk about where does it even come from?
Right.
How might your age or your gender play into it?
Right.
And really just drill down on why your experience of pain is the gold standard.
It is.
And then, we also have to talk about how healthcare providers, how do they actually assess something that's so individual?
Mm.
So lots to cover. Let's start with something that I think is probably the most common, most familiar, acute pain. What is that?
Yeah, acute pain, I think most people can relate to that.
Yeah.
It's typically that short-term pain. You bump into something, you get a little injury.
Right.
It's self-limiting, which means it usually resolves once that underlying cause is addressed. The tissue heals, the inflammation goes down, the pain goes away.
Okay, so like you sprain your ankle, it's going to be really sore for a few days, maybe even a couple weeks, and then it gradually gets better.
Exactly. Exactly. And there are certain nonverbal cues that we see with acute pain, right?
Yeah.
Things that we might see in someone who's experiencing that acute pain, even if they don't say anything. You might see guarding, for example.
Yeah.
Like they're protecting that injured area, grimacing, making sounds like moaning. Maybe they're restless or agitated.
Right.
And in some cases, you might see changes in vital signs, sweating, those kinds of things.
And when you say guarding, just so everyone's on the same page, what does that look like?
Guarding is, like if you hurt your arm, you might hold it close to your body, or if you have a stomach ache, you might kind of hunch over, almost like you're trying to protect that area from further injury.
Okay, so it's that natural instinct to shield that part of your body that's hurting.
Exactly. It's almost like an automatic protective response.
Yeah. Okay, so acute pain, usually short-term, goes away once whatever's causing it is resolved. What about chronic pain?
Chronic pain, that's the other end of the spectrum. And the main thing here is duration. Chronic pain, it hangs around. We're talking 6 months or longer.
Oh, wow. So this is not just like a really long-lasting case of acute pain.
Right. It's different. It's often a more complex issue, sometimes even involving changes in the nervous system itself. And the nonverbal signs we see with chronic pain can be a bit different too.
Okay.
And sometimes less obvious. You might see someone bracing themselves, rubbing the affected area, but they might also be generally less active.
Yeah.
Maybe sighing a lot, changes in appetite, things like that.
And I think what's fascinating about chronic pain is the variability.
Oh, absolutely.
Because, when pain is a constant companion, people adapt, they cope, and they find ways to manage it.
Right.
So those really obvious outward signs that you might expect to see, like grimacing or guarding, they might not always be there, even if the person is still in a lot of pain.
Right. Your body and mind, they find ways to cope over time, which can make it a little tricky sometimes to assess chronic pain.
Yeah, because you can't just rely on those visual cues.
Exactly.
Okay, so we've got acute, short-term, chronic, long-term. What about breakthrough pain? That sounds pretty intense.
Breakthrough pain, yeah, that's a bit of a different animal. It's like a sudden, unexpected spike in pain, a flare-up, and it happens in someone who's otherwise managing their underlying pain condition.
So like they have this baseline level of pain that they're dealing with, but then all of a sudden, boom, it just spikes way up.
Exactly.
Okay.
And there are a couple of main reasons why this might happen. One is what we call end-of-dose medication failure. This is something you often see with long-acting pain medications, where the effect of the medication starts to wear off and the pain comes back before the next scheduled dose.
Okay.
It's like the medication is working, but it's just not lasting long enough.
Yeah, it's losing its effectiveness too soon.
Exactly.
Okay.
And in those cases, the treatment might involve either giving the medication more frequently or increasing the dose.
So just kind of adjusting how the medication is managed.
Right, exactly.
Okay. What's the other cause?
The other common cause is what we call incident or episodic pain. This is breakthrough pain that's often predictable because it's triggered by something specific. So, for example, someone who's recovering from surgery might be managing their pain well at rest, but then a return to activity, even something simple, could trigger a sudden increase in pain.
Okay, so like a specific movement or even just standing up after lying down for a while could trigger that pain.
Absolutely. Or it could even be something psychosocial, like stress, for example.
So it's really about being aware of those potential triggers and maybe adjusting pain management strategies in anticipation of them.
Exactly. Being proactive can make a big difference.
Okay, so we've talked about different types of pain, but let's shift gears a bit and talk about where does it actually come from?
Yeah, let's get into the sources of pain.
Right, because you can have pain in your toe, you can have pain in your back, get a pain in your stomach.
Right.
It's not all created equal. So let's break it down.
Exactly. So we categorize pain based on where it originates in the body. One type is visceral pain. This is pain coming from your larger internal organs. So think kidneys, stomach, intestines, gallbladder, pancreas, those kinds of organs.
Okay, so if you have like a stomach ache or a really bad cramp, that would be visceral pain.
Exactly.
And how would you describe that kind of pain?
Well, visceral pain, it's often described as being deep, kind of dull, cramping, aching, or even like a pressure-like feeling. It tends to be less sharp than pain coming from the surface of your body.
Right, so not that sharp stabbing pain you might get from a cut or a burn.
Exactly. And another important thing about visceral pain is that it can be poorly localized. What that means is that it's often difficult for you to pinpoint exactly where the pain is coming from.
So it's kind of like a general area of discomfort rather than a very specific spot.
Exactly. And that's often due to the way the nerves are structured in these organs. They don't have as many specific pain receptors as, say, your skin does.
Okay, so it's harder for your brain to pinpoint exactly where those pain signals are coming from.
Exactly.
Now, what can cause visceral pain?
It can be caused by direct injury to the organ itself, but it can also be caused by things like stretching of the tissues, maybe due to a tumor, or lack of blood flow to the organ, what we call ischemia.
Okay.
Distension or even strong contractions of the muscles in the organ can cause this type of pain.
So it can be a variety of things going on inside those organs.
Absolutely.
Okay, so we've got visceral pain coming from internal organs. What about deep somatic pain?
Okay, so deep somatic pain, this is pain coming from structures like your blood vessels, your joints, tendons, muscles, and bone.
So more like the structural framework of your body.
Exactly. Think about things like a fractured hip or a second-degree burn, a broken bone, a sprained ankle.
Yeah, those all sound pretty painful.
Yeah, they can be. The causes of deep somatic pain are often things like pressure, trauma, or, again, ischemia, like we talked about with visceral pain. But the quality of the pain is usually described as more dull, aching, or throbbing.
So it's not that sharp surface pain.
Exactly.
Okay, what about cutaneous pain?
Cutaneous pain, that's the pain that you feel on the surface of your skin and in those tissues just beneath the skin.
Okay.
So think about a paper cut, right?
Yeah, that shark sting.
Exactly. That sharp stinging sensation.
That would burn.
Or a burn, yeah. That's a classic example. This type of pain, it tends to be sharp and very well localized.
You know exactly where it is.
Exactly, because your skin and those superficial tissues are jam-packed with sensory nerve receptors.
So more receptors mean a more precise pain signal to the brain.
Exactly. It allows for very precise signaling of both the location and the intensity of that pain.
Okay, so we've got visceral, deep, somatic, cutaneous. We've got one more category, right?
Yeah, referred pain.
Referred pain. That one always sounds a little bit mysterious to me.
Yeah, it's a bit of a head scratcher. This is pain that you feel in one particular spot on your body, but it actually originates from somewhere else entirely.
Okay, so like the pain is being referred from its actual source to somewhere else.
Exactly. It can be referred from either a visceral or a somatic structure. And a classic example is gallbladder pain. So instead of feeling the pain just in the upper right abdomen, where your gallbladder actually is, you might feel it in your right shoulder or your upper back.
What? That's so weird.
Yeah, it can be really strange. It highlights how interconnected our bodies are.
So pain in your shoulder could actually be coming from your gallbladder.
It could, yeah. And that's why it's really important to understand referred pain, because it can sometimes lead to misdiagnosis and unnecessary treatments if you're just focusing on where the pain is felt rather than where it's actually coming from.
Right, you don't want to just treat the symptom without addressing the actual underlying cause.
Exactly.
Now, let's talk about how things like age and gender might affect pain perception. There's this old idea that older people, they just get used to pain or they don't feel it as much. There's any truth to that?
You know, that's a common misconception, but it's not accurate.
Right.
Pain is not a normal part of aging. If an older person is experiencing pain, it's a sign that something is wrong, just like it would be in a younger person. And it's not that you just lose your ability to perceive pain as you get older.
Okay.
In fact, older adults are actually at higher risk for conditions that cause pain, things like arthritis, neuropathy, those types of things. So pain in an older adult should always be taken seriously and investigated thoroughly.
So we shouldn't just dismiss pain in older people as, oh, they're just getting old.
No, definitely not. It's always a sign that something needs attention.
What about gender? There's a lot of talk about differences in how men and women experience and report pain. Is there anything to that?
Yeah, there are definitely some observed differences in pain experience between genders. For instance, we know that chronic pain conditions are generally reported as being more prevalent in women. The reasons for this are complex, though. It's likely a combination of biological factors, like hormonal influences, but also psychological and social factors, and this is an area that's still being actively researched. But we do know that these differences exist and can influence how people perceive and report their pain.
So it's not just a matter of men being tougher or women being more sensitive?
Right. There could be real underlying differences in how pain is processed and experienced.
Okay, so we've touched on this idea that pain is subjective. But let's really dive into that. You said earlier pain is what you say it is, and that feels so important to understand.
It is absolutely central to how we approach pain. Your perception of your pain is the gold standard. It's the most reliable indicator. We can do all sorts of tests and scans, but ultimately, your description of what you're feeling is paramount.
So even if a test result comes back normal, if you're telling your doctor that you're in pain, they should take that seriously.
Absolutely. We have to trust the patient's experience. Now, we also talk about things like pain threshold and pain tolerance. Pain threshold is the point at which you first start to feel something as painful. And pain tolerance is how much pain you can endure. And these can vary so much from person to person, and even within the same person at different times.
So like two people could have the exact same injury, but one person might be able to tolerate it much better than the other.
Exactly. Pain is so individual. That's why we can't rely just on physical exam findings, vital signs, or even imaging studies to diagnose pain or determine its severity. Those things can be helpful, but they don't tell the whole story.
Right. They provide information, but they don't necessarily reflect the individual's experience.
Exactly. We need to take the whole picture into account. And that includes paying attention to nonverbal cues, even if the person is able to verbalize their pain.
Okay.
Because sometimes those nonverbal cues can give us additional insights into what the person is experiencing.
So like if someone's breathing really shallowly or they're really hesitant to move, that could be a sign that they're in a lot of pain.
Exactly. It's all part of the puzzle.
Okay, so we've talked about how pain is subjective, but healthcare providers still need tools to try and assess it in a structured way.
Right. We need ways to try and quantify something that is inherently personal.
Right.
And that's where pain scales come in.
Okay, so pain scales, what are those all about?
So pain scales are tools that help us try to measure pain, even though we recognize it's subjective. They give us a way to track changes in pain over time and to try and get a sense of the intensity that the person is experiencing.
Okay.
And there are different scales for different populations. For example, for infants and children under 3 years old, and sometimes for adults who are nonverbal or have cognitive impairments, we often use what's called the FLACC scale.
The FLACC scale. What does FLACC stand for?
FLACC stands for facial expression, leg movement, activity level, cry, and consolability.
Okay.
So we're looking at these observable behaviors that can indicate pain in someone who can't tell us how they're feeling.
Right, because they can't say my tummy hurts or my head hurts.
Exactly. So for each of these categories, the observer gives a score from 0 to 2 based on what they see. And a higher total score means more pain.
So like a furrowed brow would be a point for facial expression and crying would be a point for cry.
Exactly. It helps us to get at least some objective measure of pain in those who can't describe it themselves.
Okay, what about kids who are a little bit older? Do they use a different scale?
Yeah, for children who are 4 years and older, and for nonverbal patients or those with cognitive impairments who can understand simple instructions, we often use the FPSR, which is the Faces Pain Scale Revised.
Oh, I've seen that one. It's the one with the cartoon faces, right?
Exactly. It has a series of faces ranging from a happy, smiling face to a crying face, each representing a different level of pain. And the child just points to the face that best matches how they're feeling.
Yeah, that makes sense. It's much easier for a child to relate to a picture than to try and put a number on their pain.
Exactly. And it's important to note that young children, especially those under 4, they really shouldn't be asked to rate their pain using numbers.
Okay.
They don't have the cognitive ability to do that accurately.
Yeah, they probably don't even understand what a number scale means in that context.
Right, exactly. So for a 4-year-old, the FPSR is the way to go.
Okay, so what about adults and older kids who can communicate verbally? How do you assess their pain?
Well, one method that's very commonly used is called the PQRST method. And each letter in PQRST stands for a different aspect of pain that we need to evaluate.
Okay, let's break that down. What does P stand for?
P stands for provocation palliation. So we'll ask questions like, what makes your pain better? What makes it worse? We want to identify any triggers, like certain movements or activities that make the pain worse, and anything that provides relief, like rest, medication, heat, cold, those kinds of things.
So it's all about what brings on the pain and what helps to ease it.
Exactly.
Okay, what about Q?
Q is for quality. So here we're asking the person to describe what their pain feels like. We won't give some examples like sharp, dull, burning, stabbing, aching, throbbing, cramping, shooting, all those wonderful descriptive words.
So the way you describe your pain can actually tell the doctor something about what might be causing it.
It can, yeah. It can give us clues about the nature of the pain.
Okay.
R's for region radiation. We need to know where the pain is located. Is it in one specific spot, or does it spread to other areas?
Okay.
And if it spreads, where does it go? So, for example, the pain associated with a heart attack can radiate from the chest down the left arm or up into the jaw.
Wow. Okay. So knowing where the pain is and if it travels is really important information.
It is, yeah.
What about S?
S is for severity. This is where we try to quantify the intensity of the pain. We'll often use a numerical rating scale from 0 to 10, where 0 is no pain and 10 is the worst pain imaginable.
Yeah, I've seen that one many times.
Yeah.
But of course, even though it's a number, it's still subjective, right?
It is. It's still based on the person's perception.
Okay.
But it gives us a way to track pain over time and see if it's getting better or worse. And lastly, T.
T for timing.
That's right. T is for timing. We want to know when the pain started. Is it constant or intermittent? Does it tend to happen at certain times of day? Those kinds of things. And again, the timing of the pain can give us clues about the underlying cause.
Okay, so PQRST, it's a pretty thorough way of gathering information about someone's pain.
It is, yeah. It gives us a very detailed pain history, which helps us to make a diagnosis and come up with an effective treatment plan.
And just to kind of come full circle here, we talked earlier about objective data, things like vital signs and physical assessments. What role do those play in assessing pain?
So objective data, they're important, but they're not the be-all and end-all.
Okay.
Changes in vital signs like blood pressure, heart rate, breathing rate, those can sometimes be associated with acute pain, but pain, especially chronic pain, might not cause any noticeable changes in these measures.
So you can't just rely on vital signs to tell you if someone is in pain or not.
Exactly. And a physical assessment can reveal things that might suggest pain, like muscle tension, tenderness, guarding. But ultimately, the person's report of their pain is still the most important factor.
Okay, so to kind of wrap all of this up for everybody, pain is a complex experience.
Yeah.
It's subjective, it's individual, and there are many different types and sources of pain. And accurately assessing pain is crucial, both for healthcare providers and for individuals themselves. We have tools like pain scales and this PQRST method, but the most important thing to remember is that the individual's experience of pain is the gold standard.
Exactly. We have to listen to what the person is telling us.
Yeah, their report is the most valuable piece of information.
It is.
So I think that brings us to the end of our deep dive into understanding pain.
It does. It was a good one.
Yeah, it was good. We covered a lot of ground today. And it really makes you think about how a deeper understanding of pain can empower individuals. Because if you understand the different types of pain, the ways it can be assessed, you're better equipped to communicate your own experiences to your healthcare providers.
Right. You can advocate for yourself more effectively.
Exactly. And I think that's a really powerful thing. So for everyone listening, I encourage you to think about what we've discussed today and how it might apply to your own experiences or even the experiences of people you know who are dealing with pain.
Yeah, and maybe you'll even open up some conversations that need to be had.
Absolutely. Because understanding pain is the first step towards managing it effectively.
It is.
So that's it for today. Thanks for joining us on The Deep Dive.
Thanks for having me. It was great.
Yeah, it was great. We'll catch you next time.
Sounds good.